Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to Meet the Professor. As today we talk about the management of ovarian cancer with Dr. Antonio González-Martín, who's a Cancer Center Director at the Clínica Universidad de Navarra in Madrid, Spain. How you doing tonight, Antonio? I know it's like, 10 p.m. there in Madrid?
Yeah, thank you. I'm doing well. Thank you very much for having me in this interesting and amazing program.
Yeah, this is going to be a lot of fun here tonight. Here are some of the other faculty members, and later on we'll show you the results of a survey we did of the faculty. As always, if you have any questions or cases you'd like to run by us, just type them into the chat room. We'll talk about as many of these as we have time. As always, we have a 1-minute pre-meeting survey in the chat room for you to take, and after the meeting as well. You'll get a lot more out of the meeting if you go through that. We have one more webinar next Tuesday with Dr. Stone from Dana-Farber. We're going to talk about AML and MDS and a little bit about what happened at the ASH meeting. When we come back, we're going to start back up with some more ovarian cancer with Dr. Brad Monk and finish out this series. We're going to try some new things on that day. Then we'll be heading out to San Francisco for a couple of CME meetings at the GI Symposium, GE cancers and colorectal cancer. A couple of weeks later, we'll be going back to San Francisco again for the GU Symposium, a couple more CME programs on prostate and bladder. As we did before the pandemic, next March, we're going to have a weekend for general medical oncologists with the Florida cancer specialists in our hometown of Miami, Florida. So if you like, come on down and join us or check it out online. If you're into audio programs, check out our new program we just put out with Dr. O'Malley from Ohio State, looking at the management of ovarian cancer, but specifically related to HER2-positive ovarian cancer, something we'll maybe touch on a little bit as we go through this here today. So as always, we will be talking about some unapproved uses of medications here. We're really here today to talk about what we understand about the clinical research for these various therapies. We have a bunch of great cases to present here today, and here's where we're heading. We're going to start out chatting about, interestingly, the issue of treatment-related second cancers that has a new chapter as of last week. Then we'll go through the cases, a little bit from the survey, and then we pulled a few papers that Dr. González-Martín has done to check out for a journal club. So, Antonio, as I mentioned, we just got back from the ASH meeting. There was something pretty interesting that happened there, not related to ovarian cancer directly, but made me think a little bit about it, which is the issue of second cancers. We're going to get to that in a second. But the background to what I'm about to show you it really relates to ovarian cancer because of this, what is perceived to be an increased risk of AML and MDS. And we did a prior survey, Antonio, where we asked the faculty to estimate the excess risk for a patient who's just starting out in primary maintenance therapy with a PARP inhibitor, is going to get 2 years of therapy. What would you say to a patient about the increased risk of AML and MDS? And people mainly are hanging around the 1% mark. I'm kind of curious, what do you say to a patient? What would you say to a patient? Would you bring up the issue of the increased risk, and what would you say?
That's a great point. When we present to our patients the possibility to receive PARP inhibitors, as maintenance in first line, we always inform them about the small risk of leukemia or myelodysplastic syndrome. And the question of the patient is, but how much is the risk? So, and my answer is always the same. The risk is approximately 1%. Importantly, it is quite similar to the chemotherapy alone, which is the point here. And secondly, the benefit of PARP inhibitor in specific molecular subtypes is so important that this small risk is really not relevant when you put in the balance both things. So and the patient accept very well the risk. Having said this, when you see a patient that have leukemia, and I have a couple of patients in my clinic it is obviously it is very sad, and it's sometimes it's even tough because the patient is without relapse of the ovarian cancer, but again the risk is extremely small.
So, and what you just said is, something that, a lot of investigators would say about this same question. Incidentally, on this series, we had a case of a patient who had ovarian cancer and did develop AML. When I saw that case, I was like, oh, yeah, it's going to be PARP. And the patient didn't get PARP. All the patient got was chemo. So as you said, this is not just about PARP. The chemo presents the same risk. So why am I bringing this up? I'm bringing this up because this is not the first time that we've faced the issue of treatments that increase the risk of second cancers. This actually is true of tamoxifen, obviously, very small risk and not very much of a life-threatening risk. But I can tell you that when this came out, and this is like 2000, you can see Lancet, it caused a lot of consternation and probably had a lot to do with the fact that it really never moved forward with prevention. And then we also saw increased second cancers with lenalidomide, particularly in the long-term use that's given to myeloma patients. But again, the same kind of rationale that you described, the benefit's so much greater, but still a lot of discussion about, as you said, how patients respond. And then boom, November 29th, we see this press release. And I can tell you, in ASH, we did 4 symposia that included 21 investigators last Friday. And we asked all of them about this. And, I'm going to just briefly summarize it because I think it's important. And I think in a way ties into ovarian cancer in terms of how you talk to patients about issues like this. So this is what we did last Friday. It was a pretty wild day. We started out 7:30 in the morning. We did four symposia, finished 9 o'clock at night. Each one was 2 hours. One was 2.5 hours. And the first thing we did for all 4 of these symposium is ask these people, what do you think about this press release? I also talked to them at length before the meeting, so I knew kind of what they were thinking. And just a tasting menu of what I think you're going to be hearing over the next few months about these data. It's kind of amazing when you think about the technology we have that this press release comes out November 29th, and on December the 8th, we kind of did like a quick consensus conference. And I would say what I'm about to show you summarizes that. I think the overall feeling can be summarized best by what, for example, Dr. Abramson said.
I think this did catch a lot of us by surprise that it rose to the level of this large press release. This has always been a theoretical risk. Whenever you randomly integrate a gene into a lymphocyte's genome, there's the theoretical risk that if it integrates into just the wrong spot, which is a vanishingly low likelihood that it could be transformative. Now, I will note, if you think about the number of patients who've received CAR T cells across the globe, since this field started over a decade ago, it's a tremendous number. And the number of cases identified is an extremely low number, a fraction of a fraction of a fraction of a fraction of a percent of patients who have received CAR T-cell therapy. We've never seen a case at our center, and we're a high-volume CAR T-cell center. So I think it's something I've always talked to my patients about as a theoretic risk. I think maybe I won't use the term theoretic so much as an actual but very, very rare risk. But where we use CAR T-cells are in patients where they provide substantial benefit that has exceeded the benefit we see with conventional therapies. And so, in my mind, the risk-benefit ratio has not been swayed by this finding. We've always known there are rare and serious risks to CAR T-cells, but they're also providing truly transformative benefit to patients.
And of course, we talked all day long about cases of people who were terrible condition, extensive disease, or walking around in CRs, probably cured. So I think the overall perspective of what this means is kind of similar to what you were saying, I think, about AML and MDS and ovarian cancer, if you compare the benefit in the typical situation that you're using it. But still, I think patients do not like the idea. Any thoughts about how patients sort of absorb this kind of information, this type of toxic side effect as opposed to others?
Yeah, it depends on the context of the patient. I think that the setting of PARP inhibitors in the maintenance for patients in first-line ovarian cancer. It's a different setting that the hematological patient that needs CAR T cells, because the patient that have finished chemo feels that they have got cure. We need a lot of training to make patients to understand that what is the benefit of maintenance therapy, because at the end of the day, it's 2 or 3 years of pills with some sort of side effects and so on. So it's more difficult, I think, to accept side effects in that setting when you feel that you have finished treatment, that in the setting of the CAR T cells. I am not an hematological cancer expert, but I guess that a guy that needs CAR T cells is because the alternative is awful.
Exactly, and I think that you're picking up on this is really a great point. And let me show you an example of a comment that was made that I think kind of gets a little bit more into how patients can process it, because this is a patient who changed their minds after hearing about this. Here's Dr. Jonathan Cohn from Emory.
I think, to Jeremy's point, the overwhelming majority of times when I'm thinking about using CD19-directed CAR T therapy are for patients with relapsed aggressive lymphomas or in mantle cell lymphoma, where I would completely agree that the benefit clearly outweighs the risk that may be present with regard to this that we're discussing. Where I think there may be at least some room for debate is in low-grade lymphomas. And so I did have a patient just this past week who reached out, who was preparing to go through CAR T for low-grade lymphoma, and thought twice about that, and we discussed that there were other options that may be available. And so in this particular case, the patient was not heavily symptomatic, and so it was going to take some additional time to think about it. But that may be one place where, as we get some more information, it may be worth having a little bit more of a nuanced discussion. But for aggressive lymphomas, I still feel very comfortable recommending it.
So I think that really makes the point that you just made.
Yeah, it's the setting. Absolutely. The low-grade lymphoma and other alternatives, no symptomatic, you have options. It's not the case when you have aggressive disease without good alternative options.
All right. Well, let's move on to the cases. And, I really want to focus, it's easy to get into the discussion in terms of sort of BRCA wild type, LOH negative cases, so controversial, so difficult to manage. I thought for this one, I wanted to emphasize more patients who do have, BRCA or related issues and ideal management there, because I think it's important to make sure these people get the right therapy. And this is a case, really a very typical case. A patient presents a lot of disease, and here are the questions. She's a 45-year-old woman. She actually has germline BRCA1. Her mother and sister had it, and the doc doesn't know why, but elected not to, get worked up, to get involved with prevention, and then develops extensive ovarian cancer. Here's Dr. Wilmot.
If we're looking at a patient who has what appears to be significant disease burden within the peritoneum, how do you make that decision about whether or not you're going to proceed directly to debulking effort, or if you're going to consider neoadjuvant chemotherapy? And specifically, in which patients do you prefer to utilize bevacizumab along with cytotoxic chemotherapy as opposed to chemotherapy alone? How do you counsel your young patients who have had a really good outcome after completion of their therapy and their maintenance therapy about breast risk prevention? And for patients who have widely metastatic ovarian cancer, who unfortunately do remain at significant risk of having a recurrence from their ovarian cancer, do you feel that it's worthwhile to consider such an aggressive surgery for risk reduction from a breast cancer standpoint? This patient actually does have several children, all of whom were screened, and one of whom, unfortunately, does also have a BRCA1 mutation. Daughter, she is a young woman who's only in her late 20s.
So a lot of questions. I'm sure you hear those questions every day. I'm curious what your thoughts are. What about the issue of neoadjuvant versus not, and Bev versus no Bev?
So for the first question, in my institution, we are using the PET-CT. And if we have doubt we use the laparoscopy. But I would say that most of our patients are receiving PET-CT and laparoscopy to make the decision of neoadjuvant chemotherapy or upfront surgery, unless it's clear with the PET-CT that the optimal surgery can be achieved. If there is some doubt, we will go to laparoscopy to make the final decision. And also to take a good amount of tissue for molecular diagnosis. And regarding the second point of the use of bevacizumab in the neoadjuvant setting, we published 3-4 years ago, I think, a randomized phase 2 trial comparing chemo plus or minus bevacizumab. And what we observe is that there is no significant increment just because of adding 2 cycles of bevacizumab before the interval cytoreductive surgery. In our institution, we prefer to use bevacizumab after the surgery because we believe that only 2 cycles of bevacizumab doesn't make any difference in this patient. I'm very, very interested in the third question about what is the follow-up of a patient with a BRCA-mutated ovarian cancer, advanced ovarian cancer that is in remission. How is the follow-up of the breast cancer risk and the advice of surgery in those patients? In the ESMO guidelines about the management of these patients, one of the things is how long to define the timing to start thinking in advise a patient to perform surgery or preventive surgery. And it is more or less at least 3 years, And in a patient that has a follow-up for 3 years without relapse, we can start to talk about risk reduction surgery for breast cancer. And probably in our practice, we are waiting 5 years without relapse. With the Solo one, the Paola one, the Prima, we know that if a patient has not relapsed at 5 years, there is some sort of plateau. Maybe the patient is already cured because of ovarian cancer, and you can consider preventive maneuvers for the breast cancer risk.
I mean, I guess theoretically, if it makes sense to hold off on, say, mastectomies, but I mean, theoretically, I guess you could give tamoxifen. It would decrease the breast cancer risk 50%. I don't know how tamoxifen and olaparib get along. Have you ever done that?
No, actually, I haven't put patients in chemoprophylaxis for breast cancer. Unfortunately, olaparib do not prevent the risk of breast cancer because the risk is the same in the placebo and in the olaparib arm. But I don't have experience with olaparib plus tamoxifen. What we do is to have MRIs and I would say short follow-up of these patients.
Right. Okay. Well, I wanted to take this first case of a patient with the BRCA1 germline and use it as a way, first of all, to introduce this fantastic set of papers, issue of the Journal of Gynecologic Oncology that has a whole bunch of papers in terms of ovarian cancer. You all did the Delphi consensus process. This is like this really, very detailed, tons of stuff. This is a great paper for you to sit down and read over a weekend, I guess. There's a lot of stuff in there. But I wanted to contrast what you learned there at this Delphi consensus from your group there with what we found in our survey, just asking, 7 people or 6 people how they treat. So we came up with 4 common scenarios, and I'm going to ask you how your group, your Delphi group, whether their conclusion is similar to what we got in these 6 investigators. So 2 scenarios, either a patient gets neoadjuvant or goes right to surgery, and either BRCA, PALB2, or nothing. Sort of the ends of the spectrum. All right, so we'll start out with a patient who gets neoadjuvant carbopaclitaxel Bev, which I guess they wouldn't get in your place, at least not the Bev. But this patient gets carbopaclitaxel and Bev. And then the question is, what would the ideal maintenance therapy be? And almost everybody says Bev plus olaparib, the payola type strategy. And really, literally on the right, the duration being the duration. How do you think through this? How did your group, your Delphi group, deal with this scenario?
This is a very challenging case. First of all, as the patient has started bevacizumab in the neoadjuvant setting, we will keep on the bevacizumab in the maintenance, and we will put olaparib on top of that. That will be the consensus. But if the patient has not received Bev, I still think that this is a good candidate for Bev because the patient had extensive disease, ascites, and even with that good response, I think that bevacizumab is justified. But I would say that the consensus in our group is that for BRCA mutated patients, the PARP inhibitor alone is the preference. Bevacizumab is just for selected cases.
Well, relevant to that, you were talking about not using it neoadjuvantly because it didn't seem to improve the response rate. But what about specifically patients with ascites? I mean, bevacizumab has an anti-ascites effect. And we presented this case as a patient with ascites. Would ascites get you to use neoadjuvant Bev?
I think that all the information about ascites and bevacizumab is based essentially in the recurrent setting. There is also some sub-analysis of the GOG 218, but I think that the chemotherapy is also excellent for controlling the ascites of the patients, and it wouldn't, in my opinion, is not the main reason for using bevacizumab in the neoadjuvant setting. So that's our policy at least.
So here we have a situation, BRCA wild type, HR proficient, LOH low, but the same thing, extensive disease, ascites, gets neoadjuvant chemo, Bev, has a good response. And here everybody says Bev. Anything you want to add to that?
No doubt. Again, if the patient receives Bev in the neoadjuvant setting, we will maintain Bev for the maintenance setting.
So the issue about using PARP, though, in a patient who's HR proficient is brought up by Sarab in the chat room, who says, will you choose PARP for an HR proficient tumor, BRCA wild type? And this is something I just learned about, I didn't know existed, with a favorable KELIM score. I didn't even know what that was. Somebody brought it up in a webinar. I had to look it up here on my computer, but it seems really cool. Can you explain it and answer Sarab's questions?
Absolutely. The KELIM is how we pronounce that.
KELIM, right.
KELIM.
Yeah.
KELIM is the kinetic of elimination of the 125. You can measure that in the first 100 days of the patient when the patient start the chemotherapy, and according to the KELIM, that is a value that is calculated with an app. You can divide the patients into groups, favorable or unfavorable. Less than 1 is unfavorable, 1 or more is favorable, which is correlated with chemosensitivity and also with the prognosis of the patient. So that means that if you have an unfavorable KELIM, you have not a good response to platinum or extremely good response to platinum, and the prognosis will be worse. But on the other hand, if the patient had a good KELIM, favorable KELIM, that means that patient is extremely chemosensitive. And we are using that in our clinical practice to make the decisions about the use of bevacizumab or niraparib, for instance, in this setting of the HRD negative, or the setting that is the matter of the question, which is the HRD positive BRCA wild type. Actually, if we have an excellent response to platinum, we prefer to use PARP inhibitor alone. And we have recent data published this year, sub-analysis of the GOG 218 showing that the benefit of bevacizumab in GOG 218 was restricted or limited to those patients with unfavorable KELIM. So there are indirect evidence that bevacizumab is working much better when the response to platinum is not so good. And on the other way around, PARP inhibitors are much useful, or much more efficient when the response to chemotherapy is really good. So that is why we are using KELIM. Thank you for that question.
So yeah, I actually brought that up at a prostate cancer program recently because they kind of saw something similar with PSA, which makes sense when you think about it, because it's related to
Makes
tumor
sense.
bulk, and they saw the same exact thing. The people who had a quick drop in their PSA had a different outcome they needed more therapy, et cetera, et cetera. All right, so let's go to another scenario. Now we're in the scenario of the patient who goes right to surgery. So no neoadjuvant therapy, and they've got a BRCA. And again, you can see there's a consensus, just kidding, because you got Dr. Moore and Dr. O'Malley who are like really infatuated with Bev nowadays, from what I can tell. They're giving Bev to almost everybody, it seems. Everybody else says either olaparib or niraparib. You say olaparib. Any comments?
Oh, it's that is the case in which we had a clear consensus in our paper. BRCA mutated patient, primary debulking surgery, treated only with paclitaxel and carboplatin, and a good response. That's a patient for olaparib alone. We don't have evidence that putting bevacizumab on top of PARP inhibitor in this patient will add any benefit, and you may have some problems, some issues with the tolerability and discontinuation of the PARP inhibitor, which is the most important drug here.
And you were just telling me something before we got started that I wasn't aware of, which is in Europe, you can only use Bev once.
Yeah, that's another important point. In Europe, we only can use bevacizumab once in the natural history of the patient. So that is why if we start with Bev in the neoadjuvant setting, we cannot stop that and switch, for instance, to PARP inhibitors, because then you have partially used one of the important targeted therapy in ovarian cancer, and we cannot re-challenge the patient with bevacizumab in the relapse. That's a great limitation, and that's why we have to select very well in which patients we use Bev and when we use Bev.
So, I love all the data in your paper, but it's, kind of hard to separate it out a little bit. This is a kind of a different way to look at it in terms of whether there's consensus or not. So I only have to ask 6 people this question to say that there's no consensus on people with LOH low, HR proficient, BRCA wild type who go right to surgery. I see everything from nothing to niraparib to Bev. And you say niraparib.
Yeah, here we don't have, so a couple of comments. First is that we don't have evidence that what is the best therapy in this setting, because we don't have comparison between Bev or niraparib. So why I select niraparib in this case? One of the things that we have learned with the clinical trials with PARP inhibitors in the first line is that probably PARP inhibitors should be moved to first line and not postpone them to the relapse. And this is the typical case that you have a good relatively good prognosis because it's a good surgery, good response to platinum. So I think it's the ideal setting for use the PARP inhibitor. The problem is that the patient is HRP, homologous recombination deficient negative, and these patients have more risk of relapse. And we know that in the relapse setting, the bevacizumab will work in the platinum sensitive and also in the platinum resistant circumstances. So that's why I prefer PARP inhibitor in the first line.
All right, well, let's get into some cases. This first case is a very, very provocative case. I'll be very curious to see what you think about it. I mentioned it to you before we got started. And I think continues the theme of iatrogenic problems in oncology. We talked about how, the difficult situation of, giving a patient a therapy that has the potential to get a second cancer, which, people in general are going to get cancer to start with, so it's going to happen. But this is a very different situation, a very provocative situation. I think a situation where there's no good answer, but somehow Dr. Snyder found it. 43-year-old woman presented just like the other patient we just talked about, presented with extensive localized ovarian cancer, gets neoadjuvant therapy, and here's what happened.
This is a 43-year-old patient presented with new onset ascites, bilateral pleural effusions. This is actually a recent patient of mine. Her CA 125 was over 7,000. When she presented, this was actually when she was in California visiting family. They did a thoracentesis at the time, and that came back as high-grade serous ovarian cancer. Her sister and her mother both have a known BRCA1 mutation. She herself was never checked. I'm not exactly sure why that had failed to happen. So we recommended neoadjuvant chemotherapy given the extent of her disease and recurrent pleural effusions and ascites. Because of that, I recommended Taxol, Carbo, and bevacizumab. She presented for cycle 2. Her CA-125 had plummeted with cycle 1, so it had gone from 9,000 down to 236. She was administered her pre-meds and paclitaxel infusion. She had a severe anaphylactic reaction with a cardiac arrest.
Wow.
She was hospitalized for 3 days. She was intubated for airway protection. During that hospitalization, she did get a CT scan that showed significant improvement in her disease. So at that point, we consulted with a pharmacist and our allergist, and they recommended liposomal doxorubicin. We attempted this. Unfortunately, she had a little bit less severe, but still significant anaphylaxis to the point that the code team was called. She did not require chest compressions at that point, but it was significant. She was not intubated. Meanwhile, during all of this, her genetics came back as positive BRCA1 as we expected. So my questions for the group, because this is a new issue for me, is in this BRCA1 patient where chemotherapy showed a significant improvement, but we're having a very difficult time getting to cycle 2. She never got platinum with either of these attempts. Would anybody just consider a PARP alone?
I love this.
I tell you, my heart dropped just listening to that again. I remember the first time she told me that. Oh my God.
Yeah. So, yeah, that's an extremely challenging case. I will tell you what we would do in this case. First thing is to repeat the PET CT to the patient, because it seems that the patient had an excellent response just with one cycle of paclitaxel and carboplatin, a second attempt of PLD and carboplatin. Actually,
incidentally, I think she just got the Taxol.
Second one. Yes,
she didn't. Yeah, she didn't get the second one, right?
Yeah, only one cycle of pacli and carbo,
right,
and nothing more. But the drop of the 125 from more than 9,000 to 200 and a CT scan with a clear response. So what I would do first is repeat the PET-CT and consider surgery in this case to the patient, because maybe that before putting directly with PARP inhibitor, that is just a maintenance therapy. It's not a therapeutic strategy. It's a maintenance strategy. I would remove all the disease. Probably this patient is now in a good situation to remove the disease. And then I will treat the patient probably with carboplatin alone because she had not any sort of allergy to carboplatin, and there is no cross reaction with platinum. You can have allergic reaction to paclitaxel, allergic reaction to PLD, but there is no cross reaction with platinum. And I would put only platinum to complete 6 cycles and then PARP inhibitor to the patient. I would consider bevacizumab depending on the residual tumor after the surgery. And the only thing to discuss with the patient is the use of nab-paclitaxel that could have less allergic reaction, but honestly, after a cardiac arrest, I have seen many reactions, some of them severe, but never a cardiac arrest. So honestly, after a cardiac arrest, I wouldn't consider even nab-paclitaxel. I would put just carboplatin alone.
So, oncology, so many times there's no perfect answer. I don't think there's a perfect answer here, but here's what happened.
Allergy testing was more difficult than I anticipated it to be. My group spent a lot of time discussing this and trying to figure out what the next best steps for this very young person that's responding to chemotherapy and BRCA positive, but seems to be allergic to everything. We used nab-paclitaxel and carboplatin, and she successfully had cycle 2 without any issues. Yeah.
Wow. And that's her situation right now?
That's her situation right now. So we're about to do cycle number 3 tomorrow.
I can only imagine what you must have felt like going through. Have you ever had this happen to a patient?
I've never had this happen. So we've had significant carboplatin reactions, as I'm sure every oncologist has had. But to have this significant of a reaction, I've never seen this, especially with paclitaxel.
So I emailed Dr. Schneider last night, and patient's about to get cycle 6, doing good, and heading towards PARP. Any other comments about the case? I got a couple of questions from the chat room. Any other thoughts about this?
So I think that she was very brave putting the patient with nab-paclitaxel. Yeah, it makes all the sense because you know that the allergic reaction to paclitaxel is not because of paclitaxel, it's because of the cremophore, that is the dissolvent, I think is the word in English. But the issue here is that she had a cardiac arrest, but she was very brave and the patient is doing very well. So congratulations.
Absolutely. A couple of questions from the chat room. Sunil comment actually, severe paclitaxel related reaction, option of carbo alone. I've had 2 such cases in Australia. They both did well. So any thoughts?
Yeah, that was my advice in this case. Try to operate the patient and then put the patient on carboplatin alone.
So Gonzalo says, hi from Argentina. Would you recommend PARP maintenance to BRCA mutant stage 1 or 2?
No, we don't have data. We don't have data for that. And the risk of relapse of patients with a BRCA mutated stage 1 already treated with comprehensive staging surgery plus chemo is really, really small, fortunately, and we don't have data.
How about stage 2? What would you say? Again, given the PARP, given the chemo, what's the residual risk or recurrence after that?
Yeah, still there is still risk. Honestly, I haven't seen any patient with a stage 2 BRCA mutated since the approval of the PARP inhibitors, so I didn't have that case in front of me to make a decision. But at least in theory, I would say we don't have data. I wouldn't offer PARP inhibitor here.
All right, here's another case. I know there's a bunch of patients like this who have BRCA mutations. In this case, it was a BRCA germline, but their initial treatment was before PARP came along, before SOLO-1. So she did not get PARP the first time, now has an isolated pelvic recurrence. Here's Dr. Elsawi.
She's a heavier set patient who had a lot of carcinomatosis initially. And so we gave her neoadjuvant chemotherapy. She needed an extensive surgical operation, after which she was debulked optimally, and she received an additional 2 cycles of carboplatin and paclitaxel. Did well until 2021, where we found a 1.5 centimeter nodule in the pelvis, elevation of CA125. And because this is small, and because she has a BRCA1 mutation, we elected to proceed with chemotherapy. Gave her liposomal doxorubicin and carbo, and the node is gone, and now she's on olaparib, 300 milligrams. And that was just a clinical decision whether or not to go with secondary debulking.
So that really is the question. And he had told me too that, she's obese and, made the surgery potentially a little bit more complicated. Any thoughts? It seems tempting to take out or even radiate a isolated recurrence. What do you think about the idea of the way this approach?
So again, we have data. We have evidence that when you try to apply it to the real patient, it is not always so straightforward. What I mean is we have clear data that surgery in the relapse, in this case, can improve the overall survival of the patient if you remove all the disease. But the patient has only one small nodule in the PET-CT, if I understood well, only one small nodule in the pelvis. The patient may have some risk for the surgery. In this case, she is obese. And the question is, what is the impact of removing just one small nodule here? I perfectly understand that the option of chemotherapy followed by a PARP inhibitor is a perfect option also in this patient. But I wouldn't exclude the surgery in the future, just in case the patient has a new progression, because she can still have benefit of surgery in the relapse.
I really appreciate the docs who come on and put these tough cases out there and say what they do. It really helps us be able to think through similar situations, but I really admire these. He is saying to you, should I have done it? He knows that it's controversial and really wants to learn more. So I can't thank these docs enough. Here's another case, of course, it's sort of a simple question. How do you manage? Again, we're still with BRCA, germline BRCA1, stage 3A, everything fine, except this woman has a donor nephrectomy and an elevated creatinine. Here's Dr. Silvestro.
This is an otherwise healthy, active woman. Great shape, exercises regularly. She's actually a nurse. And she presents with a pelvic mass, elevated CA125, no ascites. She had abdominal distension. She literally could feel the mass. It became big enough. And that's what tipped her off. We tested her, and lo and behold, she was BRCA1 positive. When entering this patient's abdomen, clearly had big ovarian mass, big. The interesting thing on this particular case was because she had had a donor nephrectomy, she had an elevated creatinine.
How did she do on the olaparib? Did she have any dose reductions, any nausea, any cytopenias?
No, this patient has done great.
So I guess I asked the wrong question. I should have said, how did a creatinine do? Because when we chatted before, I was not aware of what you told me before we started. This is presented, she's been on olaparib for 2 years. Anyhow, can you comment on this case?
So we have seen that olaparib can increase the creatinine of the patients. Actually, we take care of that. That is not a formal contraindication or absolute contraindication for the use of olaparib, but it's a warning that if you have an elevated creatinine in the patient, you should ask for the support of the cooperation of the nephrologist, just to evaluate deeper how is the renal function of the patient. As I said, we have seen sometimes elevation of creatinine with olaparib. We have stopped that. And in one case, we changed from olaparib to niraparib that has less elevation of creatinine. But this case did well. We don't know the creatinine, as you said, but the patient did well.
So what about the duration? It looks like the data in BRCA patients looks pretty similar for niraparib and olaparib. It's hard to separate them out. But what about the length of therapy? Because niraparib was given for 3 years, olaparib 2 years. This patient's got BRCA. Would you use 3 years of niraparib or 2?
Usually we use 2 years with olaparib, and that is we have more data for the BRCA mutated population, longer follow-up. But if you use niraparib in this setting, I think that at least 2 years, but it is difficult to keep away of the label of the drug. The drug is prescribed or is indicated for 3 years. Probably 2 years is enough, but again, the trial was designed with 3 years.
So let's go to another case. This is a patient who was put on the trial of tumor treating fields and paclitaxel. Here's Dr. Chen.
This is a very nice 60-year-old woman. She was actually in the GOG 3005 trial, which was carboplatin paclitaxel plus minus veliparib. She then, 2 years later, developed a recurrent ovarian cancer. We actually unblinded her at that time, and she was on placebo. So afterwards, she then completed chemotherapy with carboplatin and pegylated doxorubicin, followed by maintenance niraparib. She then was on topotecan with disease progression and actually was enrolled in the TTF study and randomized to weekly Taxol and TTF and was on it for about 10 months. She then had a disease progression and has been on single-agent cyclophosphamide.
I'm curious how she did while she was on the trial of paclitaxel and tumor treating fields.
It was a device around the abdomen, fairly similar to the device for the TTF for brain. She tolerated that quite well. She's working, but she's very, very motivated patient and also is very compliant, very reliable. And certainly would try, any clinical trial, which would be helpful.
So I forgot this lady was on the veliparib trial. I want to ask you about that too, but let's start with the tumor treating fields. Of course, there's a press release out there saying that this trial, unfortunately, is negative. There was a trial presented at ASCO in lung cancer, non-small cell lung cancer, which, has some weaknesses, but still showed a benefit in patients combining it with IO. So maybe it matters what you combine it with. I know you participated in this trial. First of all, how did the patients tolerate having the vest? It's not like the head thing for GBM. They have to wear it around their abdomen. How did that go?
So I think that in terms of physical side effects, the device is very well tolerated. Only low-grade skin toxicity should be highlighted here. But the problem is the tolerability of the device, of using the device. That is, in my patients, probably they were not so motivated as the patient presented by Dr. Chen. But the main complaint of my patients was to have the device around 18 hours a day. So some of my patients really complain a lot about that. But from the physical standpoint, I would say that the tolerability was very good.
So what about this trial that she was on veliparib? It's been a while since that was reported, and it sort of fell off the edge there. But the thing that was interesting about that was they were able to give it with the chemotherapy. What was your take on why the trial didn't, like it wasn't as good of a PARP inhibitor, or the design of the trial, or why didn't it work?
I don't know the correct answer here, Neil. The trial was positive. That is, the first thing is that the trial was positive, but probably came at the same time that the Solo 1, Prima, Paola 1, without the increment in side effects with the combination. On the other hand, the Beliparib trial did not show a benefit in the HRP population. So there are many, it was not designed for that specific subgroups, but when you have data in that subgroup with monotherapy as maintenance, so many things around, and finally the company made the decision of not to send to filing that drug. That was what happened.
Has there been any interest in neoadjuvant PARP? There was this wild paper presented at ASCO a couple years in breast cancer of talazoparib, and they had like a 50% pass CR rate. And I don't know, it didn't seem to get followed up in breast, but what about ovary, neoadjuvant PARP, particularly BRCA?
Yeah, there are many, well, I wouldn't say many, but there are a few trials that are mainly proof of concept trials, phase 2, randomized phase 2 studies with PARP inhibitors in the neoadjuvant setting for HRT positive patients. But we don't have, I think one of those trials was presented this year, but with very few patients and not randomized data so far. We will see probably in 2024 the data about this strategy.
So next case, and you can understand that, we get a lot of cases presented, and we sometimes will pick unusual cases that are hard to explain. And this one fits into that. 59-year-old woman, again, germline BRCA, also actually had a history of breast cancer and actually had prophylactic BSO, incidentally, and then developed peritoneal cancer. You can comment on that as well. That's an interesting way to start out. Anyhow, she gets chemo, she gets olaparib, she gets rucaparib. She had multiple therapies for metastatic disease. And finally, without any other options, he puts her on the TAPER trial. And she gets nivolumab, although she was not MSI high, not POLE, nothing there, specific. And here's what happened.
She underwent olaparib treatment at that time because she was BRCA positive. This is before the label got removed. And that was in 2017, had 12 months of olaparib treatment and progressed on CT scan after 12 months, underwent chemotherapy with topotecan, then progressed after a month, came in with symptoms of bowel obstruction. We took her back to an open surgery, resected the segment of bowel, showed that it's metastatic cancer, put her on TAPER trial, and she went on single agent nivolumab, and she's had response for over 4 years now. So my question associated with this is, how do we find these super responders to immunotherapy? Is BRCA a biomarker for IO even better than PARP? Is a PARP IO combination going to do even better for patients with BRCA mutations?
Any thoughts on this one?
Excellent question. So I think this is a very, very uncommon case. The response rate to checkpoint inhibitor in monotherapy in the recurrent setting, platinum-resistant disease, is roughly 10%. We have seen some long-term responders in the clinical trials, mainly associated to MSI. But first thing, there is no clear biomarker. The largest study monotherapy in the platinum-resistant disease is the Keynote 100 with pembrolizumab, and we have published the translational research associated to that study. Neither the PD-L1, the BRCA, the TMB, nothing was associated to a longer response or to a higher response. So we don't have a good biomarker. So what is the reason why this patient had so profound and long-term duration of response? is extremely unknown, I would say, is I think it's a good example of the patient that we are seeing now in our clinic that do have an excellent outcome. We were talking before, Neil, that probably we need to start some sort of programs across diseases to understand who are those super responders to IO in gynecological cancer without a clear biomarker and so on. So it's a very curious case.
So I'm going to finish out with a couple of papers. First of all, TDXD, the antibody drug conjugate to HER2. We saw some really cool data from the Destiny PAN-02 phase 2 trial. This is some of the stuff that we talked about. I mentioned the program we just did with Dr. O'Malley, and he goes through this and some other HER2 strategies. But there's ovary, HER2, you have HER2 3+, HER2 2+, although I don't know if they had FISH on these. And you see response rates, in HER2 3+, 63% response rate in ovarian cancer. So bottom line, I know you put patients on this study. Did you see any good responses? Should all patients with metastatic with ovarian cancer get HER2 assays? Is this an option with HER2 low?
So I would say yes to all your questions. And let me share with you a case in our last 3 minutes. I will take only 1 minute and a half. I had a patient that I treated with nine different lines of therapy. And she was really starting to be very sick. I sent her to palliative care, but I said, I have just opened a trial for HER2 positive. Just test your tumor. And she had a HER2 positive 3+ in 20% of cells, only 20% of cells. I called her, come back, you are positive, and we can try this new drug for you. She got a partial response lasting 1 year, and she was sent to palliative care. So I put more patients. I had another complete response in a patient with more than 6 lines of therapy. To be honest, she had a small amount of disease, but very platinum resistant. And definitively, this is an active, very active drug in ovarian cancer. The duration of response is also very long. And this drug should be developing even in earlier lines of the disease, because I am convinced that this drug can cure more patients.
So this story of patients who are in hospice, on the way to hospice, and now doing well, I can tell you, this is not the first time I've heard that story about TDXD. I've heard it, and I've heard it in multiple different tumor types. So, we'll see where things head, but certainly HER2 testing and at least being aware of this as a possibility. Incidentally, we did an entire program last Thursday night, just on HER2 low breast cancer at San Antonio Breast Cancer Symposium. The faculty there was all breast, but they felt like there was, obviously HER2 low works in breast, but I don't know there's enough data right now outside of breast. Have you seen anything? I think I saw biliary maybe, but any HER2 low responses?
Well, in the pan tumor, we saw responses in patients that were locally tested at HER2 2+ or 3+, and centrally were considered 1+. So that makes another question is about the heterogeneity of the tumor. Maybe that what you are calling or considering 1+ is not 1+ in all the single sites of the tumor. And due to the bystander effect, you can have responses even in patients with low expression.
So, Antonio, it's been such a pleasure to work with you today. I think we all learned so much. Audience, you might want to check out the slide set. There are a bunch of really cool papers. Antonio put together this really cool issue of the International Journal of Gynecologic Cancer. There's like 15 really cool papers there. He did this. This is the introduction. There's a really great paper in low grade. Cool graphics. Also, PARP resistance, which fascinates me. PARP reversion mutations. Again, Stephanie LaRue put together a lot of these graphics, and also a really cool paper on clear cell. So, Antonio, congratulations. A lot of great reading for our audience. Anything you want to say about that issue and anything that came out working with these people you want to comment on as your closing thought?
Yeah, well, we are very, very close to the end. I would say this is a great great monograph, a great group of papers that are very updated with the most recent advanced strategies and therapies for gynecological cancer. Well, maybe that we don't have time to discuss, but for instance, in the clear cell, you have a lot of information about ARID1A. I also recommend to read the Stephanie LaRue paper in PARP inhibitor resistance mechanisms, how to overcome them. So there are many things in that issue that are worth to read and to learn from them.
So thanks so much, Antonio. Audience, thank you for attending. Come on back next Tuesday. It'll be our final webinar of the year with Dr. Stone, talking about AML, MDS. Be safe, stay well, and have a great night. Thanks so much, Antonio.
Thank you, Neil.